Welcome everyone. I'm Pat McBride from the Pituitary Foundation. So before we begin this evening, just a few bits of housekeeping. We have enabled closed captions, so if you'd like them, just click the CC button at the bottom of the screen. For those of you not familiar with the Pituitary Foundation, we provide support for the 70,000 plus people in the UK who are affected by conditions of the pituitary, as well as their families, friends and carers. We do want to ensure that every person affected by a pituitary condition has a timely diagnosis and access to high quality treatment, information and support. We have a dedicated nurse helpline, online and printable resources, and we work with leading medical experts to improve patient care. This session tonight will be recorded and available on our website later this year. No one's faces or comments will be visible unless you want to ask a question and have your camera turned on. To chat, please either use the chat bar or raise your hand at the end when we get to the question and answer portion of the session, and you will be spotlighted. The session will finish at 7:30. But if you do need to leave the session earlier, this is fine. I'm now going to hand over to our brilliant speaker, Dr. Matthew Heppel, for today's session called Interpretation of Test Results. We're also joined by Lottie, our Comms and Projects Assistant. Thank you.
Thanks, Pat. Hello. I'm not a doctor, sorry, just before we move on. I got a little promotion there. Hi, everyone. My name's Matthew Heppel. I'm an advanced diabetes and endocrine pharmacist, and I work at one of the NHS's tertiary centres for pituitary diseases in Hull, in sunny Hull. So I'm not sure where the rest of you are, whether we've got anyone who's local. But today I've been invited to talk to you about how we look at interpreting test results, if we look at some of the terminology, things that you might just hear as you go through your process, or if you have any family members, say with any pituitary diseases. I can see that we've already got a message that's been sent to me directly, which I will answer as we come on. Obviously, we'll start going through. Okay. Just as a little disclaimer, I'm a little bit impatient when it comes to Zoom, so I end up clicking, so I apologise in advance if the slides sort of like shoot on like that. So what I'm going to talk to you about this evening is I'm going to go through some of the terminology just around the anatomy of the pituitary. We're going to look at some common conditions related to pituitary. We're going to look at the tests associated with those and some common words that you might hear given to you in medical jargon. So the official terms for them and actually what that means and how you can understand that if it comes up in consultations, or perhaps more commonly in letters if you're copied into letters between medical professionals. So we're going to look at acromegaly, we're going to look at growth hormone deficiency, Cushing's syndrome, and hypopituitarism. Obviously in hypopituitarism there will be some overlap with some of the bits that we've talked about, but I'll not sort of go over it a second time for the sake of it. With regards to tests and assays, I do just have to say I do reference some numbers in this talk. And it's important, I guess, to start and think about the way that we have tests performed. Lots of these are blood tests, and there are many different laboratories around the country. And dependent on what assay is used in that given laboratory, they do have some slight differences between them. And so what I mean with that is that for example, you may get a number 5 in one place that might be significant, and it might not be significant elsewhere if that's the cutoff line. So a really important question you can ask when you're discussing your test results with your healthcare professionals is what are the reference values? What are the values that you're looking between for that particular assay that they've sent to whichever lab that they use? Obviously, the numbers that I've used in this talk this evening are from my own practice and my own trust in the lab that we use here in Hull. So if there is any slight differences, do just please bear that in mind. Again, no assay is perfect. No test is perfect. No test that we have is going to get every single thing every single time. And all we can do is sort of acknowledge that and know that. And that's when we start talking a little bit about sensitivity and specificity of tests. And I guess what I mean by those is that we look at how many false positives we may have or how many false negatives we have, because we need to know how good a test is at telling us what we want to know. And we'll come on to that when we talk about the assays later on. This is where I click now and then slide through a million different slides, isn't it? There we go. So what I've put on the screen for you now is just a nice little diagram of the pituitary, focusing particularly on the anterior pituitary, so the back side of the pituitary gland. So the pituitary gland obviously is a little gland that sits almost in the directly center of your head, sort of back through the nose. And it's got two sides to it. It's got the posterior and the anterior. And it's this anterior side that you can see there in orange, which does all of the endocrine bits. So it does all of the bits that affect our hormones that we're going to be talking about this evening. From that, you can see a sort of split off graph, can't you, of some of the hormones that we're going to be talking about. And I hope I'm going to be able to put them into a little bit more of a clinical perspective for you. Okay. So the most common cause of pituitary disease is adenoma. Adenoma is a type of tumor. So you might see a ton of different ways that that's put on clinic letters, for example, and it's important to understand what that means. Not all adenomas are cancerous. You can have some cancers, obviously, in the brain, but when we talk about pituitary adenoma, it's not necessarily that that's what that means. It might be a benign tumor that is causing compression or is causing impaired function in that the hormones aren't getting released the way they're supposed to. And there's a nice little diagram there where you can see the pituitary is highlighted. When we talk about the pituitary gland getting bigger or having growths or being bulky, the reason that we talk about that is to think about actually what physical effect is that having on the structures and tissues around the pituitary, because the brain's very special, isn't it? And there's a lot that's packed into all of our heads. And so we start looking to see if it's causing any issues. You might find that sometimes you hear about something called cavernous sinus invasion. What that is on the base of the brain in the skull. It's whether the growth is infiltrating, so is it going into that? The reason that that's important is if we look for surgical solutions to these growths, it's much harder to cut them out, it's much harder to resect those if it is invading other tissues. The next one, and I do apologise for my pronunciation, I'll say it with confidence. So the chiasmal compression I'll bring you down to this sort of black and white picture on the screen. The chiasm is a crossover of nerves, which you can see depicted there, and it's to do with the optic nerves, which is why quite often when patients who have pituitary diseases go for clinic appointments, what we're very interested in talking to you about is your vision. We want to know whether you're having any impacts on your visual field, because what you can see in that diagram is how pressing on one of those nerves and stopping it from working would affect what you see. So you might find that you go and you sit in front of someone and they ask you to, say, cover your eye, and then they're waving hands around here, there and everywhere, and trying to get a true overview of what the visual field is like. That's why they're doing it. And you might see in some of your letters that they've ruled out this type of compression if they've done their hand waving for you. Then I'm just going to move down to the transsphenoidal, and that's because that's the type of surgery that is performed most commonly when we resect these growths now. And the picture in the top right hand corner is of that. So you can see they go in through the nose. The sphenoid bone is almost like a butterfly shaped bone that sits behind your facial structures, just underneath the brain. It sort of is what keeps the brain in the top of the head. And so the way that they get into the pituitary is they go through that bone, which you can see here just at the end of the scope there, and it gives them access to that pituitary gland where they're able to cut away and take away what needs to be. And then finally, you've got some stereotactic radiotherapy. So that sounds much more scary than it is. I don't know if any of you have ever gone for radiotherapy before or experienced it, but it has to be very targeted. Obviously, we don't want to be damaging structures that are around it as much as we can avoid. We want the radiotherapy to go where it needs to go. As a result, what happens when you go for this type of radiotherapy is they probably place you in a bit of a head brace, and then the radiotherapy is administered at a really, really fine beam from multiple points. And what that does is it allows where all of those points meet to get a good high dose of radiotherapy. But all the other places that the beams are going through are only getting the fine beam, not the full set of them all together. So that allows us to give a higher dose of radiotherapy to where we want it to go without affecting the places around it. Okay, so I am going to move straight on to acromegaly. I am conscious now, we'll come back and look at questions in the chat later on. So acromegaly is a pituitary condition, or certainly it can be, where you have over secretion of growth hormones. You've got too much growth hormone in your body. As adults, so for children, this is very different, because children who have excessive growth hormone grow more. And that all comes down to these epiphyseal plates, which you can see in the pink lines on those bones. So on the left-hand side, you've got a growing bone, so a child's bone. And on the right-hand side, you've got a mature bone, so a bone where the epiphyseal plates have sealed. What I mean by epiphyseal plates is they are literally just lines on bone. And when you are still growing, those are the bits that extend and extend and extend and extend. And when they stop extending and they seal, it means that the bone is no longer able to extend in length. It's no longer able to extend itself. So for adults who have too much growth hormone, and therefore the middle part of the bone is still trying to grow, it doesn't have anywhere to go. And that's when we get symptoms of acromegaly, where we have overgrowth of our extremities. So you'll have like sort of overgrowth of knuckles, overgrowth of forehead, and so on. But if you ever hear someone talk about your epiphyseal plates, or your growth plates as they're more commonly called, that's what they're talking about. I've just put there on the slide about gigantism. I don't love the term myself, but actually that's the official term for when we have too much growth hormone in children, and they do grow too much, to the point where it puts extra physiological stress on their bodies. And that's sort of like a whole separate thing, unfortunately, that I'm not going to cover this evening. So with regards to acromegaly in adults, what we're looking at is how much growth hormone are you making? Is it more than we expect you to make? And there's a few different ways. Obviously, when we're trying to look at it, most of what we'll be talking about tonight is blood tests, and we're starting off in that theme. And the first one I want to talk to you about is the IGF-1. Now, some of you might have had this test done before. Some of you might go for this test so regularly when you go for your annual 6-monthly appointments, however often it is. IGF-1 stands for insulin-like growth factor. And that's a fancy name for saying that it's a protein in your body that does things, and it looks a bit like the structure of insulin, but it doesn't do the same thing as insulin. IGF-1 is made by the liver, and it's made directly in response to growth hormone that is produced by the pituitary. Growth hormone sort of comes and goes, and on the next slide you'll see a graph about how that's produced throughout the day. And you have different levels. So if I ran for a bus, I might get a bit of a burst of growth hormone. If I went to the gym and did some strenuous exercise, I would get an increased production of growth hormone. And for people who are going for diagnostic testing or for monitoring, it's then very difficult for us as professionals to interpret your growth hormone levels, because it could be different depending on what you've done that day, what time of the day it is, different between people. So we have to find a way of making that more standardized and more easily monitorable, because we don't want to have patients in hospital all day so we can get an average of your full day. We don't want to be doing that all of the time. And the way we do that is with an IGF-1. So the way growth hormone makes IGF-1 from the liver is it produces it, and it lasts a bit longer in the body than growth hormone does. So as a result, the levels are just a little bit more stable. And you imagine that if you took someone's IGF-1 at 10 o'clock in the morning and then you checked it again at 4 o'clock, it would be pretty much the same. And the levels that we need for IGF-1 in our body are related to our age. So as adults, we still need some level of growth hormone for our hair, for our skin, for our muscles and our tissues to stay healthy and turn over naturally as we would want them to. And that changes as we progress in age. And you can see, I've just put a reference graph there for you. So you can see what sort of numbers you would expect dependent on your age and your gender assigned at birth. So I guess that gives you a little bit of an idea of something that you could come back to and think, oh, well, whereabouts am I on that? The caveat to that, I suppose the caveat to all of these things is in management of medical conditions, especially ones that are as complex as these pituitary conditions and hormone conditions that we're talking about this evening, it is very much an art form. It's not a science and numbers game. So it's not like, oh, right, we've got this lady, she's 34 and her IGF-1 is 34. Oh no, that must be wrong. It depends on a few other factors as well. We don't want to be chasing numbers. We don't want patients to be having poor quality of life because we're perhaps going very hard on medications and doses to manage these things. So we have to try and balance that and have a bit of a practical and reasonable approach as well. So don't be too concerned if you find that your IGF-1 is slightly outside of this and no one seems concerned, because it's about how you feel as well. It's about thinking about you as people, not just the conditions that you have. The other way that we can diagnose acromegaly is with an oral glucose tolerance test. So you might see this written down as an OGTT. And I think I had a question about that before. So with OGTT, so it's quite often talked about by those of us who work within diabetes. It's one of the ways that we can also diagnose diabetes. And the reason that is because glucose, food, insulin, all those sorts of things have a direct impact on the growth hormone that you produce. So what you would expect is if someone has a big dose of glucose, i.e. they go and drink a pint of full fat Coke, for example, their growth hormone levels will come down. And I got a question in the chat before that said, is there a way to biochemically diagnose acromegaly when IGF-1 and growth hormone are normal due to malnutrition, for example, an oral glucose tolerance test becomes invalid because the patient becomes hypoglycemic versus hyperglycemic? That's a new one on me. I've never had any of the patients that I've worked with who've had hypos in response to us administering glucose. I'm not sure if the person that's asked that question is perhaps thinking about another form of test, but please do put some more in the chat to me on that and I'll come back to it. This is where I click again. There we go. So there's that graph that I was talking to you about before, looking at the different ways that growth hormone is produced and the different levels that you'll find throughout the day. The way that we would monitor acromegaly, depending on whether or not it's active acromegaly or inactive, naturally if there was an adenoma or a tumour there that was causing lots of problems, a surgical intervention and removing that issue might be the way that you and your endocrinologist choose to go down. But for patients who are sort of managing along, they might just get monitored, and we monitor that with an IGF-1, because as I said, it gives this better overview, this better stable level throughout the day. You can do tests where you do look at growth hormone directly. That would be called a growth hormone day curve. And in that, you would have to come into an outpatient area. Some of you might have had this done. You come in and we check growth hormone levels standardly throughout the day. And we do a little map, like the one that you can see on a little graph, sorry, like the one you can see on the screen. And then we take an average, and that will give us an average of your growth hormone for the day. The difficulty with that is there's so many different variables that can affect it and that can change the results. And it's not as widely used because it takes a lot of professional time and a lot of patient time as well, you know, just to come and sit in an outpatient area. You might sometimes hear or read in a letter about a nadir growth hormone, and that's the lowest level of growth hormone that you would find on one of these day curves. Because within the curve, there is still a maximum and a minimum amount that you wouldn't want to go above or below. And so we will look at your average throughout the day, and we also look at what's your lowest level of growth hormone in the day as well. And that lowest level will be your nadir growth hormone. That's what nadir means, lowest. Moving on to growth hormone deficiency. So growth hormone deficiency is almost like the direct opposite of acromegaly in that you don't have enough. And there's a few different ways that that can be diagnosed. I'm going to talk a little bit about insulin stress test, which is just a specific type of test, and the results that come from that a little bit later on. We don't tend to use insulin stress test first line if we're just concerned about growth hormone deficiency. It is a fantastic test, but it's got some risks associated with hypoglycemia. It's really not very pleasant for patients at all. So we try to do these glucagon stimulation tests where we can and where that would be appropriate for our patients. Basically what would happen is you come into an outpatient area, you're given some glucagon, which is the opposite hormone to insulin, so it makes your glucose rise, and we see what happens. So what you should see, because the glucagon is suppressing insulin, is you should see a rise in your growth hormone because it's sitting in balance with those other hormones in your body. If it's not rising, then that's suggesting that you've got, so if it doesn't rise by 3 or above 3, that's suggesting that you've got severe growth hormone deficiency. Sometimes patients can have a partial rise, so you might have partial growth hormone deficiency where it comes up a bit, but you're not really still getting the response that you would expect. And that graph is just from when the test was first validated back in 1970, looking at what you would expect to see from a glucagon stimulation test. I'm very conscious of time, so moving on, I'm just going to move on and we'll look at questions at the end if that's okay. So looking at Cushing's syndrome. So Cushing's syndrome is where patients have too much cortisol, they have too much stress hormone. And that can happen for a number of reasons. It can be driven by the pituitary, but it can also be driven by, say, cancer somewhere else that's causing production of cortisol. And so the first things that we have to do is, one, is identify if we are having too much cortisol produced, is this actually a Cushing's syndrome? And then after that, we move on to trying to figure out why is that Cushing's syndrome happening? Where is it happening from? And then we go on to thinking about how we're going to solve that. So the first tests that we would do to look for Cushing's syndrome would be a 12 or a 24-hour urinary free cortisol. And so that's basically where we ask patients not to go to the toilet so that they can save up their urine. And then we collect that urine sample and look for how much cortisol is in that urine. It depends. So some places will ask you to do a 12-hour, some places will ask you to do a 24. The 12-hour has a different sensitivity and specificity to the 24 and the 12 have different, but it's not too far different. They're both pretty good tests. They're both quite reliable. And what you're looking for, is there a high level of cortisol in the urine, which would warrant further investigation? If you've got someone who has all the symptoms of Cushing's syndrome and you don't necessarily get the test result that you are expecting, sometimes endocrinologists will still proceed to do other tests to try and rule it out as much as possible. And the things that we do to move on and confirm Cushing's is the 1 milligram overnight dexamethasone suppression test. And we also do a late night salivary cortisol as well. So the overnight suppression test, you get a dose of a drug called dexamethasone, which is a steroid, similar family as prednisolone or hydrocortisone, which some of you might take. And we ask patients to take that cortisol, that steroid, at midnight, so between 11 o'clock and midnight, and then come into outpatients to get blood levels done of their cortisol the day after. And what you're expecting to see is, can that dexamethasone suppress that cortisol production? Is that steroid able to push down the amount of steroid that your body is making? Because these things sort of sit in balance. So if we give you lots of false steroid, you would expect your body not to need to make as much. If it's not able to suppress it, certainly if the level is greater than 280 nanomoles, then that's showing you that Cushing's is probable, because what you're having is still very, very high productions of cortisol, even though you've got a drug that should have pushed it down. For late night salivary cortisol, so patients without Cushing's will usually have salivary cortisol at bedtime because it's coming out, and that'll be lower than 4. patients with Cushing's will still have that, but at higher than 4, because all of the levels are higher than they should be. Hopefully what should happen in someone who doesn't have Cushing's or someone who doesn't have pituitary diseases is that when we get ready to go to bed, when we're winding down for the day, our stress hormone winds down as well. We're not needing that stimulant anymore because we're needing to rest. That doesn't always happen, and it doesn't happen for patients who have Cushing's syndrome. I don't know, I wonder whether I have a high cortisol at bedtime because we run around everywhere, run around after kids and this, that and the other. But I would still expect that I have a salivary cortisol less than 4 at bedtime, because you're getting ready to go to sleep, your body's shutting down. But for patients with Cushing's, they're not able to do that. So their cortisol production is still very high, and they might report things like poor sleep because of that. If you get a positive test for Cushing's from the overnight DEX suppression test or from the late night salivary cortisol, then that's when we start knowing that there's Cushing's there, and we have to look a little bit further. So we go on to look at these 2 hormones particularly. Sorry, I'm just looking at the questions. I will answer them there. So with regards to the 2 hormones that we're looking at when we're trying to decide about Cushing's syndrome, is we look at the adrenocorticotropic hormone, which most commonly is shortened and will be on letters to ACTH. And that's the hormone that stimulates cortisol production by the adrenal glands that sit on top of your kidneys. So that's the hormone that comes from the pituitary, and that's what works on the adrenal glands to produce the cortisol. But there's a ladder above that as well, and that's where CRH, the corticotropin releasing hormone, comes from. So quite often what you'll find in these sorts of ladders or pathways of hormones is that you have one that comes from the pituitary, which does the action. So for example, the ACTH causes release of the cortisol, and growth hormone causes IGF. You also have releasing hormones, and they're further up the tree, and they come back from if you go back and have a look at the diagram on one of the first slides of the pituitary, you'll see that there's hormones that come in from the hypothalamus, which is another part of the brain, and that hypothalamus controls the pituitary. So they're sort of like the headquarters of the hormones of the body. And so the hypothalamus sort of feeds off what is in the body. Are the levels where we expect them to be? Oh, they're not. I'll tell the pituitary to do something else then. And say, for example, hormone levels are low, it might produce a releasing hormone to cause an increase in levels. So that's what CRH stands for. And you might see that if you're going for CRH testing. This is where I become blocked with the screen again. So CRH testing can be done in 2 different ways. You can either do CRH testing with another dexamethasone test, or you can do it without a dexamethasone test. And the first one that I've got on the screen is with the dexamethasone. So what we do is we give dexamethasone late at night, and then we test. We give the corticotropin releasing hormone as well. And what you would expect there is, if you're giving a releasing hormone, you would expect that that's going to cause a rise in cortisol, but also a rise in ACTH, because the CRH feeds the ACTH, doesn't it? This is not from our trust. I think this is from Bristol Trust. But hopefully, if you were getting a letter with regards to these, to do these tests, you would have to go in as an inpatient, because obviously most outpatient departments aren't open at midnight for you to go into them. And that would be really horrible, wouldn't it? So you will have an inpatient admission for these. And so the tests should be readily available for you to discuss with someone while you're on that ward area. So in patients who have the releasing hormone without the dexamethasone, say someone who had normal cortisol and pituitary function, you'd expect that ACTH would go up because you've given the releasing hormone to start that happening. If you have, after you've given someone CRH, if you have a rise from their basal, so we do a blood test at the start to sort of get an idea of where you are. If you have someone whose cortisol goes up by 20%, that's suggesting that actually, no, this is a pituitary problem. And equally, if you have someone whose ACTH rises more than 50% from what it was originally after the CRH administration, that again is expecting a pituitary source. You can get this sort of cortisol production from other sources that don't come from the pituitary, and that's where you would expect to see that neither of those bloods go up after you've given the releasing hormone, and that's because that stimulation, that extra hormone is coming from somewhere else, and that's when you would have to start thinking about other sorts of carcinoma or adenoma elsewhere that are releasing cortisol. I'm just going to move on to hypopituitarism. Hypopituitarism is probably where I have most experience. This is most of the patient group that I see. And the first thing that we start looking at is more dynamic focus of testing. What I mean by dynamic testing is that we're going to be taking a few blood samples at once, or we'll be taking lots of blood samples in a row. And that sort of gives us a better overview from one test or two tests from the whole host of hormones that the pituitary gland secretes. So we'll be looking at thyroid, we'll be looking at growth hormone, cortisol, and the gonadotrophins as well. And we'll be looking at them all in one, because what we want to know is an overview of how much pituitary function has that person lost, and where is it lost, so we know what to supplement, so we know how to treat. So I'll start with the insulin stress test. An insulin stress test is, and you'll be able to read about it on the Pituitary Foundation website. Pat, who so lovely introduced me, I was reading an article that she'd written about her experience of that. Yeah, I read it today, but I read it yesterday as well. And it can be quite a harrowing experience for patients. I have type 1 diabetes myself, so I know all too well how horrible hypoglycemia is when the blood sugar is too low. And with an insulin stress test, what we are purposefully doing is giving someone insulin to make that stress come on. We're trying to cause that stress. For those of you that drink alcohol, if you imagine the worst hangover you've ever had, that's kind of how hypoglycemia feels. But the difficulty with this test is you are left feeling like that for a little while, and it's not something that you've perhaps experienced before. Which can be really harrowing. It can be sometimes hard to sort of know what to do. Hypoglycemia changes the way that your brain thinks and feels. I certainly know when I have a hypo, I become very teary and I get really upset. And so it's sort of, there's that edge to the sword as well. Not only are you undergoing this quite difficult test in a very clinical scenario with lots of people around you, but you also, the test will actively make you feel unhappy and stressed as well. So what we're trying to do, obviously, because it's so awful, it needs to be worthwhile. Insulin stress testing is kind of like the gold standard for diagnosing hypopituitarism, looking at different pituitary hormones, because we do get such reliable information from it. The difficulty is it's not suitable for everyone. So for example, I wouldn't be suitable because of my diabetes, because you wouldn't want to induce hypoglycemia in people who have extensive cardiovascular disease aren't suitable for this test, because hypoglycemia can cause sort of damaging cardiovascular events in people that already have extensive disease, and also people with epilepsy, just to name a few. And that's because in those patients, the risk of the complications of the test are much more increased than people who don't have epilepsy, don't have cardiovascular disease, and the benefits become not as worth it on balance. There are other things that can be done. So for example, I've already talked about the glucagon stimulation test that we can do to look at growth hormone and cortisol production. Although the glucagon stimulation test isn't as good at cortisol as it is at growth hormone. And there's also a new drug that's just come out sort of end of last year, start of this year, that most centres are looking to use now as well, which can help with this. So don't worry if you think, oh, I'm really not suitable for this insulin stress test. There are a few other things that we can do. what that test would involve is when you go in, you would have cannulas put in so that we can readily take blood samples, because you'll be taking a lot of blood samples. And that gets put in the antecubital fossa, which is, if you look at your arm, if you look down at your arm, it's kind of like the triangle space that sits. You can see I put a little diagram on this very well vascularized cartoon, but that little triangle sits there, and that's where all of the cannulas and everything go. And that's also where we give the insulin straight into the vein, and where we'll draw blood samples off as well. What we do is we'll take blood samples from patients hourly, and we also take blood glucose, so the standard finger pricking, and we check that every 5 minutes. And the reason that we do that is because we want the growth hormone and the cortisol levels to be taken from the blood when we know someone is having hypoglycemia, when we know they're in that period of stress. So if you do have hypopituitarism, so if you are diagnosed as having, and quite often patients get hypopituitarism post-operatively, so say they have an adenoma, say they have acromegaly, and surgically we go in and we cut that away, it's really difficult. If you go back and have a look at the picture that I put on the first slide that we did, it's virtually impossible for surgeons to resect it with such sort of specific cuts that it would leave enough of a pituitary there to function normally. There's just no way that they're going to be able to do that. There's no science to that. And equally, if you have something like a growth, like a benign tumour, it needs to be all cut away so that further growth doesn't occur. As a result, you find that you might be hypopituitary in 1, 2, 3, or all 4 different areas. And you tend to find that they're like a ladder. So you lose them in a certain order. But this is the order that we're going to go through them today. And rather than me telling you that order, everyone's different. I don't want to sit here and say, oh, because I would hate for someone to worry and think, oh, why have I lost my cortisol first when perhaps it should be thyroid or whatever. It's not sort of like that. We're all individuals. And actually the most important thing is that you get correct testing, and then that we can supplement you properly. So for patients who are cortisol deficient because they don't have enough ACTH coming from the pituitary, we supplement those patients with hydrocortisone. What we will try to do with tablets is sort of make a similar sort of spikes in steroid in the body. So we need a big amount in the morning to get us up, and then we need a little bit more at lunchtime, and then we need a little bit more at evening meal, and not a lot overnight because we're not up, we're not doing anything, and you don't want to be stimulated when you're trying to sleep. So similarly to the growth hormone day curve that we looked at before, you might find that you're invited for a hydrocortisone day curve, where we ask you to come in to the department before 9 o'clock. You take your hydrocortisone, say you get there at 8, you take it, say 7:30, and then we will regularly check your cortisol levels every hour throughout the day. You carry on walking around as normal, you eat and drink as normal, just in our outpatients department, or whichever centre you're at. And then we look at the doses of hydrocortisone. And what that gives us is it gives us a brief overview, it gives us a brief guide. So what I've done is just a little example chart of how that might look, and some examples of reference ranges that would be usual for most of the tests that we've done. So for example, you would expect that people are higher in the morning, so 500 to 800s. At lunchtime, again, you get a bit of a peak, so between 400 and 500, because this is in response to us you taking some hydrocortisone, is giving you hydrocortisone. And again, in the evening, you get a little bit of a peak as well. But you can see there very clearly that you need a lot to get you up in the morning, a bit for you to be walking around and doing your tasks, your living during the day, and then less as you get towards winding down for the evening. Quite often you hear about patients who aren't fond of their hydrocortisone, they get kept up at night. And that's because the later you take that dose, say you take your last hydrocortisone dose at 7 o'clock at night, for example, that's probably going to keep you up at night because you've got that stress hormone that's keeping you awake. It's what wakes us up in the morning. So we commonly advise that that's taken sort of early morning, lunchtime, and then about 4 or 5 o'clock. And you can even bring that a little bit forward as well if you find that you're still having problems. We have some patients that have gone to twice a day dosing instead of 3 times a day. And if that is something that you're concerned about, and you've never had one of these day curves, it is something that you can go and ask for to see if you are on the correct dose of hydrocortisone and how that looks for you during the day. What we wouldn't want to see when we're doing a cortisol day curve is a peak of more than 900, because that would suggest that that dose of hydrocortisone is too great for you. It's too much for you. It's more than what you need. But we also don't want to be seeing any trough values, which are the low values. We don't want to be going below 100, because you do sort of need stress hormone to be getting around and living throughout the day. So that's kind of like a rough guide of values for you. If you do go for one of these, there's no reason that you couldn't ask for a copy of your numbers if you wanted to have a look and keep a copy of the chart as well for yourself. Moving on to the thyroid. So the thyroid is sort of a very common condition, but thyroid pituitary disease much less so. So because thyroid disease is very common, you might find that GPs, pharmacists, ward nurses or community nurses have some awareness of thyroid disease, but it might be that they're not aware of the type of thyroid disease that you would expect in someone who has pituitary disease or hypopituitarism. So with the structure on the right hand side, that's kind of the process of how thyroid hormone is released. So you've got your hypothalamus, like I said, that sits in your brain, and that's going to give out thyrotropin releasing hormone, so TRH. That TRH is what stimulates the pituitary gland to produce TSH, which is thyroid stimulating hormone. But in patients who have pituitary disease, that's the bit that doesn't happen. So no matter how much stimulation that pituitary gland gets, if you have hypopituitary because it's been resected away, then that gland is no longer able to produce TSH. It's no longer able to make the stimulating hormone as you would need. So as a result, you would get low thyroid levels because there's nothing that's telling the thyroid that you need more. In patients who have a normal pituitary function, what you would expect to happen there is the hypothalamus would tell the pituitary to make some TSH. The TSH would tell the thyroid to make some thyroid hormone, and you could check the levels, and they should hopefully be in some sort of balance. The difficulty with looking at T4 levels is the reference range, so the range of numbers that we see is quite wide for the hormone, which means that I could get, say, 100 people in the room, and we might all have sort of very different numbers, about 10 or 5 apart, and all be well and healthy with it. So standard reference range for T4, which is thyroxine, is 10 to 25. And we all sit at a different point within that 10 to 25. You might have someone who is at 12, and that's enough and normal for them, even though that's the lower part of the range. You might have someone who's at 20, 24, and that's okay for them, which makes it very hard when we then need to supplement thyroid hormone and try and decide where we're trying to get for someone who has pituitary disease. Naturally, we don't want to give you too much thyroid hormone. Thyroid hormone is a bit of a rate setter within the body. So you might, if you know anyone who has thyroid disease, if they have low thyroid, they might have had slow heartbeat, they might have felt a bit sluggish, found a bit of a brain fog, because everything's slowed down because they haven't had that thyroid to keep the pace. Equally, or conversely, I should say, if someone has high thyroid output, everything's going a bit too fast. So you might see that their hair gets thinner. You might find that they're sort of rushing around, can't hold on to thoughts, because everything's going a little bit too fast for them. And so it really is about finding that sweet spot in the middle about what's right for you as an individual, rather than just all patients. What we try to do is we try to supplement thyroid with levothyroxine, and we aim for somewhere in the middle of those numbers, so somewhere around the sort of 15 to 19 mark. There was a sort of consensus that you kind of aim for the upper half of that where you can, but the difficulty with that is you will have, if you take any population, naturally half of those would usually sit on the lower spectrum, so you don't want to be pushing patients either way. So aiming for the middle is kind of the best we can do in balancing people out. And then after that, we really are guided by patients telling us about how their lives are at home. I know it's incredibly hard, isn't it, when people come into clinic and they say, oh, so how are you? And you're expected to tell them, and you might not have seen that endocrinologist or that professional in a year's time. How do you sum up a year of life, especially with everything that's been going on at the minute? It's really hard to summarize that. But what we're looking to know and looking to see is how is your day-to-day life? Are you finding that you're very fatigued? Are you finding that you're not able to complete tasks? Those sorts of things. Before we joined this call, I was talking about a patient who I've recently seen, who was on the thyroid supplement because they were hypopituitary. And the difficulty that that patient had, as many patients with hypopituitary have, is that healthcare professionals who aren't familiar with complex endocrinology conditions like hypopituitary can fiddle a little bit because they don't know that they don't know what they don't know, I suppose is what I'm trying to say. So how we would standardly manage thyroid disorders that aren't linked with the pituitaries, we would look at the TSH. And if the TSH is low, then that means they've got too much levothyroxine, which you can see on the middle scale on the left-hand side. So if you've got a low TSH, that usually would mean that you've got too much thyroxine. But in someone who's got pituitary disease, that's not the case at all. And so what can sometimes happen is patients get told that they need a dose reduction or something needs to change with their thyroxine, when actually it's got nothing to do with the TSH at all. It's all about the T4 level. And if the T4 level is in a good range and the person feels well, there's no reason to change that dose. There's no reason to fiddle. And you really do have to sort of advocate for yourselves on that with practitioners who aren't as familiar. And that brings us on quite nicely to the gonadotrophins. So with the gonadotrophins, and I will be quick with this because I'm conscious of time. So that's a group of hormones, particularly FSH and LH, which again are produced by the pituitary gland, and they're what stimulate the gonads. So they stimulate the testes and the ovaries to produce sex hormones within our bodies. So most of you might remember FSH or LH through like sex education or biology at schools. And these are the hormones that cause release of the sex hormones within our bodies. Again, there is a releasing hormone that stimulates those, and that's gonadotrophin releasing hormone. And I'm quite glad because the names aren't all that complicated, are they? But more than often what happens in clinic letters is we as healthcare professionals abbreviate. So you might see GnRH in one of your letters and think, well, what on earth is that? So when you have someone who you suspect as having low gonadotrophins, you can use a GnRH test to see if you can stimulate that production. At the bottom, I've included Kalman syndrome. Kalman syndrome kind of sits a little bit separately to hypopituitary, but there was no other really good place to put it. But Kalman syndrome is where you would be deficient in gonadotrophin releasing hormone. Yes, Christine, I will write that down in the chat for you at the end. So Kalman syndrome with gonadotrophin releasing hormone is you're purely deficient in that. So you might be fine with all of the elements of your pituitary function, but it's just this one that specifically that you are deficient in. So looking at what is a normal LH level, what is a normal FSH level, and unfortunately this is more difficult for females than it is for males, and that's because we have the added complexity of the menstrual cycle, where these LH and FSH are changing throughout the cycle in relation to the reproductive cycle, whereas in men it's much more common. And I always feel a little bit guilty when I talk about that because it's so much harder for women when they're looking at these, having to think about dates, thinking about when their last period was, thinking about if they're in a state of menopause where they perhaps have varying LH, FSH levels as they're in between before they move to this post-menopausal stage. But those are some numbers, those are some reference ranges that you can go back and look at. What you would expect in someone who is hypopituitary, if they are having problems with their gonadotrophins, you would expect those to be low. Normally what we would do is we'd look at LH levels, FSH levels, testosterone, estrogen all together, and we would check those as a blood test, and we would just look to see, are they in a reasonable range for where we expect that patient to be? And if they're not, if they are too low, that's usually enough to base a diagnosis off, but there are a few other tests that we can do. But if you wanted to refer back to those levels, The clomiphamine test is one of the tests that I was talking about if we're looking at gonadotrophins, and we use this sometimes in Kalman's. And basically what it does is it blocks the action of estrogen, which is what then stimulates the hypothalamus to produce LH and FSH. So by blocking those actions, it makes the body think that there isn't enough estrogen. So as a result, as a reaction, what the body does is it says, oh, I'm going to make loads of LH and FSH to try and make that work. And so over the few days, you would expect to see those levels of those gonadotrophins rise. That usually takes about 2 to 4 days to appear, but in both males and females, you would expect LH and FSH levels to have doubled by day 10. In Kalman's and in hypopituitarism, you don't see that rise. So we might use this test if we're not expecting total hypopituitarism, if we're just looking at gonadotrophins, but we also might use it as part of hypopituitary workup as well. If you do find that you're deficient in testosterone, we have a ton of different ways that we can supplement that. And the reason that I've included this is because it's one of the most common problems that I encounter in my practice for patients who are treated with testosterone. And you see this quite a lot in people who use the drug recreationally, is that there can be rises in hemoglobin levels. So testosterone as a hormone has other functions rather than just the sex hormone functions, where it is related to the way that we produce red blood cells. As a result, if you have more testosterone, you can also have more red blood cells. What that does is it in its worst state is it can thicken the blood, and that increases risk of things like stroke, heart attack, because if you imagine a more viscous fluid floating around the body, it's more liable to clot, it's more liable to getting stuck and sluggish in places, isn't it? The good news is that most commonly we use the second line down in practice to treat low testosterone levels and hypopituitarism. So we would first try to use the long-acting injection, because patients only have to come to hospital once every 3 months, and it gives us a good amount of testosterone cover, and then that's it. They can lead their lives. They don't have to think about it. They're not having to do something every day. And that formulation, that medication, has the lowest chance of increasing that hematocrit. So hematocrit as a term is kind of a measure of how much red blood cells are in your blood. So if you have a very high hematocrit, you would have a high hemoglobin, you'd have a high amount of red blood cells in the same blood volume. If you have a low hematocrit, then you would imagine that the blood is a bit thinner, it doesn't have enough, similar to how and someone who is anemic. We can do things if we do find that we're getting raised hematocrits in response to testosterone, and we do sometimes try the gels, which you can see further down, and while they do have a higher rate, because they're not necessarily applied as thoroughly as the injection works so easily, we sometimes get better results with that. Or we can extend the dosing interval, so we can give, instead of giving it every 12 weeks, we might give it every 16, just to see what we can do. Some people choose to come off testosterone for this reason, and that's entirely up to you and your endocrinologist to have that discussion if this is something that you are experiencing. I'm conscious of time, so I'm going to skip over diabetes insipidus, just because it sort of sits separately from the other sort of anterior pituitary conditions that we've talked about this evening. There is some information about diabetes insipidus on the Pituitary Foundation website if you wanted to have a look. Diabetes insipidus is very complex, and is diagnosed in a very difficult way. Some people go for a complex test called copeptin, which is what I've got here. But there is information available on the website if you did want to have a look at that. Thank you. I'm very conscious of time, Pat. I think I might just have a quick look at the questions, if that's all right.
Yeah, of course, yeah.
So I've seen the first one. I did ask if someone, I don't know if they've had a chance to have a look at it. What's the best way to diagnose insulinoma due to MEN1 with associated pituitary? Is there a false negative test result as in acromegaly. So all assays that we do, all tests that we do will have some element of false negatives. And that's when we need to start looking at the specificity and sensitivity of that test. So it would depend what test it is that you're referring. The way that we would diagnose insulinoma is commonly now we would utilize things like Libra patches, so which are commonly used in monitoring of diabetes, which will give us an overview of someone's blood glucose over a 2-week period, and we can see how often they're experiencing hypoglycemia and how long that hypoglycemia is going on for. If they are having notable hypos, then we would bring them in for a 72-hour fast. So we'd ask them not to eat for 72 hours, just clear fluids. And if they do have a blood glucose of less than 2.2, then we would take insulin levels. And if we find that they then have high insulin levels and are having hypoglycemia despite having eaten, then that would be positive for an insulinoma, because that insulin isn't getting produced in the standard way in response to glucose. What is normal cortisol level around 9 a.m? So I don't know what a standard cortisol level would be for a patient without any sort of cortisol dysfunction. Oh, sorry, that's my watch speaking to me. I expect it would be the same as what we were aiming for patients on adequate replacement. So because we're aiming for somewhere less than 900, between the 500 and the 8, because that's the time that you're getting up and around in the morning, I expect it somewhere within there as well. Some patients on replacement steroids find they need to take small dose of hydrocortisone when they go to bed to get them through the night. So I've only ever come across that in, I think it's only about 2 or 3 cases. And the people that I have spoken to also have trouble sleeping. We have some patients that go on continuous hydrocortisone pumps, which is something that is, you can have a look on the internet about if you wanted to. And that gives us the ability to sort of decide how much hydrocortisone we're given in a 24-hour period. I'm not suggesting that people don't need any hydrocortisone overnight. They do, that they need some cortisol at all times in their body. I guess what we're trying to do is make sure that the levels are low enough that it's not disturbing their sleep, which can have a huge impact on quality of life. What do you expect the levels of a female who does not have a cycle with regards to FSH and LH? So for a female who doesn't have a reproductive cycle, that would be dependent on why she doesn't have a cycle. So if that is because she's postmenopausal, i.e. we have a medically induced menopause, then you would expect the hormone levels to be more similar to that. And it depends why she wouldn't have a cycle. That's a bigger question, I think there, Emily. Matthew, I've been on all types of testosterone and I've had to stop them. I went through puberty and aware that this affects my bone density, but I've not had anything for over 2 years. Is it true that for me to go through it would kill me? I'm not sure about that, Peter. That would depend on different factors that are related directly to you. So, for example, weight, height, and we would try to tailor that. That might be why. So, for example, say you are a bit taller, do you need more testosterone? And actually what you were trying to get to, that would be a conversation that we'd better have had with your endocrinologist. And if it's something that's really important to you, you can write to them, and then obviously you'd receive a formal letter back if you didn't want to wait for your next appointment. Makes sense. The first blood glucose went up 3.9. So I thank you for clarifying with regards to oral glucose tolerance test and hypoglycemia. What I would say is that for patients who have insulinomas, they have hypoglycemia when they haven't had any glucose intake, because what that would show is that they are producing insulin that isn't linked with glucose at all. And that's because a group of cells have started to produce insulin inappropriately. Whereas what it sounds like you're describing is that you have had a glucose tolerance test, you have taken in 75 grams of glucose, either be that Lucozade or something else. And as a result, there has been a lot of insulin produced in your body that has caused you to have low blood glucose. So that doesn't sound like an insulinoma to me, but obviously that's, I can't really comment on any of your individual cases here, can I? Because it's, I don't know you and I don't have access to your notes and so on and so forth. And then someone sent me a direct message as well, which I won't read out. I'm going to stop there, Pat, if that's okay.
Yeah,
I will
no,
put in,
that's fine.
if you give me some time just to write in, I'll write in about the thyroid, which someone asked me to as well.
Yeah, of
Yeah,
course.
thank you.
You ever so much, Matthew, and for bringing your expertise tonight. It's been really enjoyable. And thanks to all of you who've taken the time to join in this session too. Thank you all for being with us this evening, and if you are able to donate, please go to the Foundation website and the Awareness Month. Thank you. Thank you.